Dr. Sarbjit.
So when the going get tough, the tough gets going. So my presentation is the difficult lenticule extraction in silk due to different reasons. I have no financial interest. So let's go directly to the case. So the meniscus sign is very important when you are getting into the lenticule. First, we have to differentiate the anterior part of the meniscus, anterior part of the lenticule, and then the posterior part. And the meniscus sign, this is very important. So just sharing that when everything goes right, everything is in your favor, so the lenticule comes out very easily and take only few seconds to come out. This is the dissection of the anterior plane. Although so this is the normal case.
So surgeon is how many lenticules down in this case?
Before this surgery, this is the surgery of the initial days. We have installed this machine in January.
Okay.
So I think this is in the March.
Right.
The dissection is little difficult during that days. But although it was even that days, time was around less than 1 minute. So this is the normal dissection that normally we do, and this is the day when you are a king, when you think that you are the king and everything goes according to you, and the lenticule is out very soon and everything goes. But the days, all the days are not yours. You are not the king all the time. Sometimes the problems are waiting for you. So even the king is not the king. So these are the scenario when you have to deal with a lot of things that are waiting for you to trouble. So this is the case with the OBL. So although we have seen the OBL in the center of the cornea, center of the lenticule, but everything goes well. The opaque bubble layer didn't do any discomfort. Everything gone well. The dissection was little tough, but even then the things gone well. So I don't know how to fast the video. Can you? So that was the normal video. So these are the video with the complication, the more complications. So I was treating this patient. I have requested him to go for the silk, for the normal LASIK laser, but he says no, he will go for the silk only. So I have tried silk because the lenticule was very thin. So when the lenticule is thin, then its chances to go into the wrong plane are very much. So first we have to go into the anterior plane. But I was thinking that I am in the anterior plane, but after some time I realized that I was in the posterior actually. So I have tried to find out the anterior part of the anterior lip of the lenticule, but the trouble starts here. So I couldn't make it out. I've started to find out that how to enter into the anterior plane so that I can dissect the lenticule. But in spite of many attempts, then I started with a forceps just to lift the anterior part so that I could go into the lenticule.
What is the refractive power of this case?
What is the
refractive error?
Minus 1.7.
Minus 1.7.
So now I have not doing the thin lenticule. Normally I am doing silk. If the case the number is more than minus 2.5. So I avoid to do in the thin lenticules because all the complications that I have are met with the thin lenticules. So when you find the anterior lip, the dissection was very safe and very easy. So no problem. So this is the thing that with with time or with experience, you get into that, how to be dissecting the right plane and how to get it. The meniscus sign is very important. Go into the right plane. So you can see the tear on the entry wound. So, directly, this is the meniscus sign, so I will not discuss it. Only few minutes more. So this is the incomplete photo disruption. We can see the lenticule tear in this case. Entry was good, but you can see when I tried the last part of the lenticule, there was a tear. This happens because of the incomplete photo disruption, and the part of the lenticule was attached to the inferonasal part of the cornea with the stromal side, maybe because of the incomplete dissection. So I have tried to pull it out, but it was difficult. It was, then I have just a little pull. I could make it out. I have dissected it again from the bed, from the posterior part. So the inspection of, in such cases, the inspection of the lenticule is very important. Like the retained lenticule into the bed may lead to a lot of problems, but thanks to God that everything gone well. The lenticule was intact, and on the next day, anterior segment OCT, there was no retained lenticule in the bed. So the third day post-op was 6/6. So this is the last case. Here, I am doing a patient who has the refractive error of -1.25 with -0.5 cylinder, and in this case also the lenticule was thin and it was folded. When I was trying to make it out, you can see the lenticules folded from the one side, and it was very difficult to remove, and it was attached from the posterior part. So in the nutshell, although with a little gentle pull, I could make it out. So we have done more than 206 size in last 6 months, but the complication was more in the initial phases, but the results are very good after proper energy optimization and surgical skills. Thank you so much.
Yeah, thank you so much, Dr. Sarbjit. So I think the most important thing is to first go in anterior plane. No?
Yes.
So once you miss that, you enter in posterior, then
yes.
it's very difficult for you to find the right
Yes,
plane.
that is the main.
And initial cases, of course, everyone says that don't take up less than 2 diopter.
Yes.
Your lenticule is very thin, and then
and it is very difficult to make it out.
Yeah.
Dr. One point is if you are not sure whether it's anterior or posterior, at least do half anterior, half posterior. Do not completely dissect. Even if you think that you are in the anterior, but if you completely dissect, then it becomes very difficult.
Most of the time we are very sure that.
Case, but it's always to be safe rather than being sure.
Yeah.
So do not completely dissect. Just do a little 2 millimeters only, and then on the other side, and once you are sure you are in 2 different planes, then you can finish the dissection. Another thing that you showed about incomplete femtosecond, if the patient has a few, nummular or nebular opacities, then that can cause an incomplete penetration. So that should be seen pre-op.
Thank you.
Thank you very much.